Good evening. Over the next 12 minutes or so, I will discuss the use of stem cells for the treatment of articular cartilage disease. The rationale for the use of biologics, whether they are used alone or as an adjunct to surgery, is largely based upon their ability to either be anabolic or actually anti-catabolic to modify the arthritic process. But I think it's best to think about it not only as it affects cartilage, but the entire organ, including synovium, MSCs, and subchondral bone. Now, stem cells. Clearly, there's fact from fiction. We all need to separate this out. And to start, we really have to think about what are they. Stem cells are unspecialized cells that have the ability to self-renew, and they can actually differentiate into various cell types. So they can come either as pluripotent or multipotent. But in the United States, most of the focus is on multipotent stem cells. Now, there are a number of ways to actually define stem cells. These are nucleated cells, so you can look at the total number of nucleated cells, but you have to keep in mind that monocytes and other nucleated cells can appear, at least histologically or by cell count, as stem cells. So to get more specific, we can actually look at cell surface markers, whether they're present or not. We can create colony-forming units, which is basically an assessment for their functionality, but in the reality is that terminal differentiation is probably the most specific to actually assess for stem cell function. Arnie Kaplan is probably most credited for describing the function of stem cells as really functioning as medicinal signaling cells, not necessarily terminally differentiating to a certain cell type, but functioning to recruit other stem cells, secrete bioactive factors, and to modulate by creating a very strong anti-inflammatory effect or even modulating the immune system. There are several strategies to obtain stem cells that are available to use, such as bone marrow, adipose tissue, synovium, peripheral blood. They can either be concentrated or expanded, injected intra-articularly, or at the time of surgery. Now, there are some benefits to concentrating them because it's considered minimal manipulation, so relatively easy to get to the FDA, and it's a single-step process. But it does create a heterogeneous mix of cells, and there still is only a very small number in terms of the terminal yield. Now, these cells can also be cultured and expanded, obviously, to achieve higher numbers, but there are issues pertaining to contamination during the amplification process, and that invokes regulatory demands that you otherwise wouldn't have if you simply concentrate the cells. Now, because of this regulatory burden, there's really only been one level 1 MSC study to date in the United States, and that's this article that the first author, Tom Van Ness, authored, basically looking at allogeneic marrow stem cells mixed with hyaluronic acid. And this was in a meniscectomy patient population who had concomitant osteoarthritis. And essentially they showed that lower dose stem cells did better than higher dose. As I mentioned, the FDA poses a significant obstacle to stem cell therapy. And the burden is really by therapeutic class. The easiest is our class 1 and 2 devices, such as screws and plates. And it gets much more complicated as we go all the way up through biologics in terms of what the relative regulatory burden is in getting these through the FDA. The lowest level burden is really the 361 classification, and these are really lower risk products where they are registered with the FDA, but they require no clinical study. And those are some examples that you see, such as vascularized tissue grafts and whole blood, and maybe bone marrow aspirate. Now, the more rigorous pathway is the 361 pathway. The FDA recently came out with a guidance document describing the components of the 361 classification. And essentially, they have to be minimally manipulated, homologous used, cannot be combined with another article, utilized in a single operation in the operating room or in the same clinical setting, and they can't have any systemic effect or be dependent upon the activity of the cells for its primary function. Now, bone marrow concentrate is the number one system that's available to us in the operating room today or in the office. And essentially, this is where we obtain 50 to 60 cc's of bone marrow aspirate, and essentially you get a 14 times or more concentration of inherent MSCs that are present essentially as parasites along the cancellous bone. Now, these cells have been shown to have phenotypic stability, and if you want to look at the components of PRP, it's essentially, of bone marrow aspirate, it's essentially like PRP with an increased concentration of MSCs after it's been spun and concentrated, but there's also generally an increased number of white cells and less fibrinogen, so its clotting potential is somewhat less. So why would you want to concentrate bone marrow? Well, if you just look at the number of colony-forming units, once bone marrow aspirate is concentrated, there's a significant increase, as shown in the slide provided courtesy of Gus Mazzacca. Now, it can be challenging to obtain MSCs, and what you can do in the operating room setting is you can generally go to the area where you're working. So if it's a knee procedure, we've used the proximal tibia. If it's a shoulder procedure or other, you can go to the anterior and posterior iliac crest. Because I use lateral decubitus for instability, if I decide I want to use MSCs, I can go posteriorly. Beach chair position affords us while the patient's laying down to go to the anterior superior iliac crest. And then the other is the proximal humerus, which if you're doing a humeral or a glenohumeral-based procedure, they can be easily obtained. Now, there's not clear-cut guidance as far as where we should go and what gives us the greatest yields, and there clearly needs to be some additional work in this area. But suffice it to say, it seems that the mainstay of bone marrow aspirate continues to be derived from the iliac crest, and that's largely from the hematology literature and transplantation literature. But using the posterior anterior iliac crest seems to be the primary location. But you can get significant yields from the proximal humerus as well as the proximal tibia. Now, what about the use of bone marrow aspirate concentrate in osteoarthritis? In general, what we're seeing is a number of level 4 studies, and the challenge is that many of these studies come from the pain management literature, and this is a very heterogeneous population that is often pre-treated with prolotherapy and subsequently treated with a composite of maybe abdominal fat and bone marrow concentrate. So because of this heterogeneity, it makes it very difficult to draw conclusions. My point about the heterogeneity in the existing literature was really emphasized by a systematic review published by Zia and co-authors. And essentially what they showed is that the current level of evidence is low quality, very incomplete, and is associated with very small sample sizes. So it becomes very difficult to draw conclusions about the existing literature showing the potential benefits of bone marrow aspirate concentrate and the treatment of osteoarthritis. Suffice to say, if it does work, it's likely working through a mechanism that treats the arthritic milieu. In other words, what the synovium is doing, what the role the inflammatory mediators play, and is likely not contributing in any meaningful way to structural changes across the diarthrodeal joint. Now, it really begs the question, if we don't see the clinical data, does it intuitively make sense to use bone marrow concentrate in osteoarthritis? Most of you are familiar with orthokine or an IL-1 receptor antagonist system where blood is taken, spun down, cultured with glass beads, and incubated, and essentially a series of 3 to 5 injections are used, and the mechanism is proposed to be that there's a component of IL-1 receptor antagonist to reduce the signs and symptoms of osteoarthritis. So when recent research that was provided to me by Lisa Fortier showed that when you compare PRP and bone marrow concentrate, when you look at the cytology, like I pointed out, you do see an increased number of neutrophils and monocytes compared to PRP, but there's also an increased amount of bioactive proteins in bone marrow concentrate compared to PRP. So when you look at the important growth factors such as VEGF and TGF-beta and so forth, we see a significant increase in concentration and amount compared to platelet-rich plasma. What's also interesting is that bone marrow aspirate concentrate has interleukin-1 receptor antagonist, just like has been proposed to be present within orthokine and similar products. So that may offer some additional benefits. So intuitively speaking, it may make sense that bone marrow concentrate does a reasonable job in reducing symptoms associated with osteoarthritis, but we still need the clinical data to support this. There's also abundance of data that has looked at bone marrow aspirate concentrate in focal cartilage defects. And essentially, these are studies that often don't have a cohort, again, showing a series of patients, for example, using bone marrow aspirate and microfracture with a type 1-3 membrane, and a number of other studies that have looked at marrow stimulation augmented with bone marrow aspirate concentrate. Again, intuitively, it makes sense. We think the presence of growth factors stimulating the presence or chemotaxis of additional MSCs can upregulate the local environment. So this is just a case example taking advantage of that hypothesis. This is a 43-year-old male who has symptomatic OCD in his right medial femoral condyle and has been complaining of weight-bearing pain that's restricted his activities. He also has tenderness along the medial femoral condyle in normal alignment. This is an MRI taken that was, we had the opportunity to get serial MRIs, and you can see over time that he's had progression of this defect with changes in the subcondylar bone. And he adamantly did not want an osteochondral allograft. So here's a video of the defect being evaluated, and you can see that the area that's involved is actually smaller than what we see by MRI, but clearly reflects that there's significant damage along the defect with unstable edges. And the area of the exposed bone is subsequently what would be treated with marrow stimulation, in this case augmented by bone marrow aspirate concentrate, as well as biocartilage, which is essentially an anhydrous scaffold used as a carrier for platelet-rich plasma or bone marrow aspirate concentrate. So just reflecting on this lesion, it is not uncommon for the lesion itself to actually have a larger zone of injury by MRI compared to what we see clinically. So in this case, we treated the subchondral bone effectively with subchondroplasty, where we injected calcium phosphate into the area as targeted by MRI. And then within the joint, we performed a marrow stimulation technique and combined anhydrous collagen from an allograft collagen biocartilage combined with bone marrow aspirate concentrate to hydrate it, and then using fibrin glue over that to seal that into the defect. And then these are MRIs seen 1 year postoperatively. You see almost complete resolution, still some presence in the bone marrow, but nothing like we saw pre-surgically in terms of the subchondral signal change that he started out at time equals 0. Now, the more complex pathway is the 351 pathway, where bone marrow is actually cultured or adipose tissue is actually cultured. So it's another use of MSCs, but the contention is that we can increase the number of cells and hopefully derive a more dramatic response. And there are a few level 4 studies looking at case series, looking at cultured adipose and cultured marrow cells to augment cartilage repair and osteoarthritis. We have a little bit of experience in this area, including a clinical trial that was a early phase 1, phase 2 study looking at marrow stimulation augmented with adult MSCs derived from placental cord blood. And the outcomes coming from Korea are actually fairly impressive when compared to marrow stimulation alone, even in a population of patients that tends to be very advanced with bipolar disease. So more to come on this, but this pathway will require formal clinical study, and we're probably 3 to 7 years away from seeing anything that's reasonable for the treatment of localized cartilage defects using cultured either bone marrow, adipose, or other derived stem cells. So in conclusion, the FDA regulatory process for MSCs seems to be a bit of a moving target. There is increasing oversight, and there tends to be a business risk aversion to derive these therapeutic options given the financial impact and the size of the market. But I think the next available market that many are looking at is truly osteoarthritis. And while we may not be targeting disease modification in the near term, if we can simply reduce the symptoms of osteoarthritis, including pain and swelling, we would go a long way. And that's where many of the studies currently are going towards. But there's a significant compliance burden that largely depends upon the source of the cells, the degree of manipulation, whether or not these are used homologously, in other words, used in a way that they were initially intended for. Because currently FDA, for example, says that adipose tissue was really never meant to be injected into a diarthrodeal joint, so it should probably be considered as non-homologous use. So there's a lot of dialogue going on with that specific aspect. And then finally, whether or not the MSC is going into the donor, so it's autologous, or it's coming from a donor, going into a patient, allogeneic, has very different ramifications as far as the regulatory burden. Thank you very much for your attention.